Okay. This conference is now being recorded. So, good afternoon, everyone. My name is Annie Rosenkrantz. I serve as the program manager here in the Center for Global Citizenship. We're so excited that you all are here for our annual Atlas Week debate. SED, which is the SLU Association for International Debate, is a student organization that is administered out of the Center for Global Citizenship. It promotes international understanding and the practice of communication through discussion and debates between students from St. Louis University, other nations, and other parts of the United States. We debate topics of global significance that really allow us to express and discern our rights and responsibilities as global citizens. For the third year running, this Atlas Week debate is the result of a partnership with SLU's Center for Interprofessional Education and Research as a part of the IPE Healthcare Systems class. Tonight's debate will bring SLU debaters together with debaters from the University of New England's Interprofessional Education Collaborative. The purpose of the debate is to promote dialogue around issues of national and global importance. So this year's topic will center on health insurance systems, with SLU students arguing in favor of the motion and UNE students arguing against. Today's debate motion is a single-payer government-based health insurance system provides greater benefit to citizens than does a private-payer employer-based health insurance system. So our debate will utilize a British parliamentary-style format. SLU's side, known as the proposition, is responsible for arguing on behalf of the topic, on behalf of the motion. So they will be arguing that, yes, a single-payer government-based health insurance system provides a greater benefit to citizens. UNE's team, on the other hand, is the opposition. They will be responsible for arguing against the motion. So they will then be arguing that no, the private payer employer-based health insurance system is actually providing greater benefit to its citizens. The way British parliamentary style is formatted is there's the SLU side, the proposition, and then there's the UNE side, the opposition. Each debater will alternate. So first SLU will begin, then UNE, and back and forth sequentially till we get to the end of the debate. Each debater gets 7 minutes to present their argument. The first minute and the last minute is protected time, and the debater cannot be interrupted by the other team. In between this protected time, however, speakers from the opposite bench may interrupt the speaker with points of information, which are questions or comments from the opponent. The speaker may accept the point of information or reject it, and simply ask the opponent to sit down. So our judges will deliberate at the end of the debate and determine the winning bench. While our judges deliberate, we'll open it up to the audience who may have questions for our debaters here today. So thank you all for attending. I'm going to close this out. Yes, okay. I'm going to invite now Gerardo Rodriguez, who is the coordinator of SED, to introduce his debaters, and then UNE will invite you to introduce yours. Thanks.
Hello, everyone. Thank you for coming for our Atlas debate. As we mentioned before, we have as part of the debate, there's two houses, the upper and the lower. And so for the prime minister, which is part of the upper, we have Joseph Delormier. As deputy prime minister, we have Kayla Hannon. As part of the lower house, we have a member of proposition, Amelia Meigs, and as government whip, we have Bryce Hughes. We pass it on to UNE to present their debaters.
Hello, SLU. My name is Matt Devine, and I will be the member of opposition.
I'm Liz Crawford, and I'm a graduate student in occupational therapy. I am opposition whip, and I've also taken on leader of opposition also.
I'm Lauren Zito. I'll be the deputy leader of opposition. I'm an occupational therapy student as well.
I also missed the fact that I'm a physical therapy student in the UNE grad program.
Thank you, everyone. We look forward to a great debate. I'd like to invite SLU's Prime Minister to please join me here and get us started.
Healthcare systems throughout the world provide varying advantages and disadvantages for their application in diverse states. The purpose of this debate is to discuss whether a government-based single-payer healthcare system or private-payer healthcare insurance provides faster, more reliable, or more economical services to a country. A single-payer system is defined as a system in which a public or quasi-public agency organizes healthcare financing. However, the delivery of care may remain with the private sector. This means that one organization, almost always the government, controls the collection of funds and the reimbursement of private or public medical institutions. Additional insurance for diverse coverage may be offered by private insurance organizations in single-payer countries. A country which utilizes private payer insurance contains many privately owned insurance companies which may or may not have to meet standards set forth by the government. Coverage for citizens relies on their personal expenditures towards healthcare insurance. This debate is important to determine the expanse of state intervention in healthcare systems in all countries, yet especially in these crucial months in the United States presidential race. Conservatives take the side of little to no government spending on healthcare, while liberals call for the extension and continuation of the Affordable Care Act posited by the Obama administration. The Affordable Care Act extended single-payer programs such as Medicaid and Medicare, which in itself are single-payer systems, yet the United States is not considered a single-payer country. The United States is one of the few developed countries that lacks universal health care as stated by the World Health Organization. Universal health care refers to a healthcare system which provides basic equity of coverage to all citizens in a country. Single-payer coverage is not a form of universal health care, as can be seen with the ACA in the United States. Yet single-payer is an efficient mechanism that allows countries to strive for universal coverage. In an ideal world, which no doubt we should be striving for both in this debate and in reality, every country would have health care for every citizen, and there would be no great financial burdens associated with this care. Single payer is the most efficient way to aim toward these goals in the modernized world that we live in. There are many countries that choose to keep the financing of healthcare in multiple pools, either to increase competition or to reflect the needs of different regions. Swiss citizens overwhelmingly have voted to keep multiple pools rather than go for single payer, while the Netherlands contains a system of competing funds that has existed since the early 90s. Both of these systems require compulsory insurance to be obtained by all citizens. These systems may look attractive in that there is a separation between insurance agencies that serve a high number of low-risk people from other agencies that insure mostly high-risk people. However, the World Health Organization has suggested that single contains several advantages, including greater efficiency and the capacity for cross-subsidization within the population. When kept in separate pools, each agency has the incentive to take low-risk people, and populations that receive more benefits are not willing to share funds with the populations that are worse off. In the United States in particular, fragmented pooling is perceived to be one of the reasons for the failure to reach universal coverage despite high levels of health spending. When a central agency takes control of all financing, risk equalization takes place. People and businesses in rich geographic regions with few health problems contribute more to the tax pool and do not receive as much coverage, while citizens in poor regions contribute less to the pool, but generally receive more than they contributed. Some countries with these allocation methods employ complex allocation formula to decide fair appropriation to various geographical areas and facilities, as stated in the 2010 WHO report. Fragmentation can lead to inefficiencies. Systems that utilize many different funding channels, each with its own administrative costs and efforts, are expensive and require separate coordination. Duplicating systematic parts of the healthcare industries, such as running hospitals, distributing medicines, and supporting lab systems, results in unnecessary waste. Fragmentation of the healthcare spending, instead of maintaining a single unified payer system, results in superfluous spending. A single payer system of healthcare creates significantly increased possibilities for universal healthcare than a private payer system offers. Universal healthcare is desirable for a number of reasons, including disallowing millions to suffer because they lack insurance, economic gains that are possible when all are insured, and a lack of dissonance that exists when there is not healthcare for everybody in a world that increasingly believes in equality and justice among all citizens. A head of household who is laid off from his or her job and cannot pay for a child's asthma treatment should not be made to watch his or her child suffer because of factors outside of his or her control. Universal healthcare is the most morally pure system of healthcare and should be an objective of every developed country. Achieving this goal is most effectively accomplished when utilizing the single payer system. One way that this could be implemented in the United States is, instead of abolishing the Affordable Care Act, extending it to all Americans. The single payer system that the Obama administration created is the most likely course that the country holds to achieve universal coverage in the future. Though this may not be plausible in the current economic climate of the country, we believe that this is the direction that the country must attempt to embark upon if we should wish to remain a competitive and ethical leader in the modern world. Thank you.
All right. Can you guys hear me? Okay. You bring up some really good points. I think something that we both parties definitely agree on is that there's is that we're definitely in. This brings up a big ethical dilemma with regarding healthcare. Our country's definitely involved in a healthcare crisis right now for people's health, chronic disease rates, and the uninsured and the need for more preventative healthcare services. I think an important point for everyone to look at is everyone having health insurance does not necessarily mean that everyone will suddenly be healthier. It allows easier access to services, but a single payer system does not necessarily mean that the quality of care is going to be there. With Medicare, Medicaid services now, and VA hospitals, we do see really high wait times. And you mentioned other countries that have a more single payer model. And it's not, sometimes there's myths involved with that, that's the best way and it allows everyone to be healthier. It can blanket and allow ease of access, but the quality of care is not necessarily there. In Canada, for example, there's really high wait times for people, so much so that people will even seek medical treatment in America if they can afford it. So it's not necessarily the best way to go. And it's important to keep in mind the costs for this. There's different models that get thrown out there right now with political debates going on. And a lot of it sounds really good. The idea of it does sound really good. We're not disputing the fact that the idea is appealing, but unfortunately you do have to put money into things in order to make it happen. And having the government in control of everything is not necessarily the answer to that. We're currently in debt with the Medicare, Medicaid services we're already providing, so it's hard to say that putting even more of a burden on the system is going to be functional. And so I just want to reiterate that we do share some common ground on recognizing that the current system is not perfect. But the issue we're pointing out is that a true single payer system is not necessarily the answer to solving all those problems. Thank you.
So I would first like to start with, I will talk about the issues that the opponent has risen, and then I will go to strengthen the opposition side. So the strengthen the proposition side. The opposition side has stated that one of the biggest issues with the single payer system is that even though it helps everyone get covered, it doesn't necessarily give them the best health care. But that's actually a very common misconception. They specifically cited Canada, which, yes, they for certain procedures, they do have a high wait time. And then they stated that that will lead to people to come over to America. The issue with both of those statements is that while, yes, some of them do have long waits, therefore what's considered non-vital procedures, Canada is a very specific single-payer system. This is not found in pretty much any single-payer system we came across in our research, where they specifically decide that for non-vital procedures, some of them are hip replacements that don't affect their everyday life, that there is a wait. And this was done specifically because they wanted to, they have a certain amount of money for their healthcare, and they decided to put that money, instead of having less wait for that instance, they would implement it and put it to clinical research and helping in the clinical day-to-day help. But to say that that is a serious problem is more of a misnomer and more misleading than an actual truth, because they specifically do this. They could change it, but they've decided that it is better and that there is more, there's a preferred outcome when they allocate it to clinical services. And then the statement that Canadians will come over to America to get this service is actually not based in facts. So according to the Health Affairs, there is one Canadian a month who will go over to America for a specific procedure.
If you can just speak.
Yeah.
I have a point of contention. Going back to the wait times, I'd like to bring up a statistic that really compares Canada, which is a true single-payer system, to our current United States system. On average, Canadian citizens who report going to the ER, greater than 24% report having to wait longer than 4 hours. In the United States, only 12% report having to wait longer than 4 hours. And
I would like to
specialist. I'm sorry. In terms of seeing a specialist, in Canada, 57% of citizens report having to wait longer than 4 weeks to see a specialist, where in the United States, only 23% have to wait longer than 4 weeks. So in terms of saying that it's not serious procedures, having to wait in the ER or having to see a specialist, for someone who has a cancer diagnosis or suspects cancer, having to wait 4 weeks could be the difference in having that disease metastasize or not metastasize and getting their treatment.
So you assume when you said that, you assumed that the people who have to wait that long are the people who they have 4 weeks where it could metastasize or not metastasize. Canada does a system where it is based off of vitality. So the people who are more likely for it to be life and death get priority over those who are not, which is why they have long waits. And I'd also like to emphasize that those people actually get to go to the ER. And in America, many people do not even bother because they cannot afford it. Because we do not have healthcare in this country, you cannot afford it even if it is life and death, or if it's not life or death, it is still very severe. And in fact, the World Health Organization has stated that we actually have a larger care, like issue to care gap than Canada does, because while in Canada they have to wait for service, in America, due to costs, many more people are not capable of even going to the ER, even going to the specialist. Okay, so I would,
You you have to be seen by a physician if you do go to the ER. They can't turn you away for not being able to pay for services. So
yeah, but you then are forced to pay, and that's why a
and
lot
the
of
medical bill, you can be charged medical bills, but medical bills do not go against your credit. So if you do not pay, I mean, it's unfortunate, but it doesn't mean that you're not going to get the care that you need. If you walk into the hospital, you will be cared for, and you will be
yes,
seen
they
by.
will still rack up a lot of debt. You can go into hundreds of thousands of dollars of debt, and just because it doesn't go against your credit doesn't mean that it's still not things that you have to pay for. I could name, I don't have
You're
statistics, but I could
absolutely
name all.
right. You're absolutely right, and there is a flaw in the system. But my point is that people do go to the ER when they need care.
But the problem is it's not just a flaw, it's a very serious flaw, and I apologize, but I have to get back to the rest of my speech. So they stated that that single payer will help give universal health care, but it won't be greater health care. But um, I would like to state why that is actually not true, because one of the instances of single payer is it's not socialized medicine. You're not actually you're not actually preventing the medicine itself. A lot of single payer countries have socialized medicine where the um, doctors and physicians and hospitals themselves are regulated by the government, but this is not what a single payer health insurance system is. And so there should be no difference in the actual service of like quality of service, because it's not intruding on the actual health care facilities. All it does is simply um, increase the ability for people to afford health insurance, and then would decrease costs due to, as what the prime minister said, would help it's called a pooling effect, which is when you have, so in America, we have a lot of very poor people and a very rich people, and we have very low risk people and very high risk people. And so um, health insurance companies don't like to allow people that are high risk because it's not worth the benefit. But when you have a large pool, when everyone is in one pool, then it sort of equals out. Those who have to pay a little bit more because they're low risk and have high risk people in their pool won't have to pay near as much more as the amount of high risk people have to pay less. And so it actually benefits the most amount of people. The World Health Organization has cited this, and the AACA has cited this as well, which is the American Association for, so the AAMA for medical students. Um, and I have run out of time, so sorry. Oh, I have 8 minutes then?
What I didn't count the when they make the question. I don't count that time because it
Okay.
takes time off. You still have time left.
Do you know how much time I have left?
You have 2.5 minutes left.
Okay. Oh, sorry, I thought that was on my times. I'm sorry
If I
for.
may bring up a point of contention. So going back to saying that the quality of care is not going to decline, but in an article written by Canadian physicians, they quote that the savings and the increase or the savings and costs from implementing a single payer system. The quote says it usually has come from restricting access to publicly insured medical goods and services, from not paying the full cost for innovation of medicines and technology, underinvesting in new hospitals and equipment, and then holding down the wages paid to health professionals. So, in order basically to fund the system, they have to restrict the access of their citizens to receiving services. They have to restrict the ability to research new and more efficient drugs, and they have to limit the amount of technology funding that goes in the hospitals. So the hospitals are not going to have the best of medical equipment, and therefore the quality is going to be less.
So that is one of the issues that Canada has, because not only they're a single payer health insurance system, they're also a socialized medical system. And so they've decided, so they not only, the government is not only controls and regulates the health insurance, they also control the medical, um, like the clinical services and the technology and and everything that goes into medicine. This is not an aspect of that. I am not disagreeing with you that Canada has some issues and some arguably massive issues, but that comes from it being socialized medicine, which is distinct from a government-based single-payer health insurance system. Because nothing about a single-payer system particularly includes socialized medicine. It can, and in many places it does, but it doesn't have to. There are many countries that have a single-payer health insurance healthcare system, but not a socialized medicine system. Does that answer your question?
Yep.
Okay. So 2.5 minutes? 2 minutes. Okay. So one of the reasons that I would like to just go back to supporting the proposition is that, especially for those who in America know, there is a massive issue in being able to afford health insurance. Because if you can't afford health insurance, then you have to pay out of pocket. In fact, there are two factors that are most likely to bring a middle-class citizen to bankruptcy: children and illness. Because if you can't, even with our current health insurance system that does very little, well, it does significant, but not near enough to curb the cost of health insurance, it can actually completely, the healthcare costs can be so massive that it will bring you to bankruptcy, which is why a lot of people, they go to the ER when they have to. But that's because it is life and death. And they didn't go before because their health insurance didn't cover it, or they did not have health insurance. If you have a universal single-payer system where the government controls the health insurance, then they can regulate what it allows. So when the Affordable Care Act was implemented, they required the health insurance companies to to not be able to force the companies to accept those who have pre-existing conditions, which is a big element. And then if everyone has universal health care, then they don't have to pay out of pocket, which is absorbently, ridiculously expensive. Or the health insurance quality can also be increased because it can be cheaper, and the government can regulate more things that a private health insurance company would not be like to do. Thank you.
Okay, so what we are going to talk about is that a lot of your arguments are based on assumptions, and assuming that this is going to bring costs down, that quality of care is going to remain high, and that giving and having access to through a single payer system is going to lead to a healthier America. So one thing is assuming people don't go to the doctor only because lack of healthcare coverage. There are other reasons why U.S. citizens are not going to the doctor. It's fear, lack of education, lack of transportation, lack of just access, cultural competency, and also that they just don't want a health lecture. A lot of people already know the answers. And they don't really want to hear it. So assuming people will go to the doctor appropriately and assuming people will go to the doctor sooner. So we really think that our focus needs to be more on preventative care. And preventative care requires access to grocery stores and transportation, ability to implement the kind of lifestyle changes and behavior changes that are going to actually manage chronic diseases, which is one of the highest reasons why people are going to the ER for care. So access to healthcare doesn't necessarily serve all of the problems, and going to a single payer system is actually going to cost the United States a lot more and put us further into debt than working within the framework that we already have in our country currently through the private payer system. Allowing those who can afford healthcare to pay for their own healthcare through private entities. And then, as you said before, we also agree that expanding the ACA and allowing for those who are in the uninsured population to gain health insurance. However, we do not think that the way to do this is to implement a complete single payer system within the United States at this time. So right now, the VA hospital can be considered a pilot study for what universal health care would look like or single payer system would look like. And right now, wait times are 3 to 6 months and sometimes more. Veterans are currently dying waiting for care. In the Phoenix VA, there was the secret appointment list. Somebody had to prioritize who was going to get care. And if through a single payer system, who is going to organize that? Who is going to decide who is going to have the access to care? We're going to have more of an issue than we already have. I don't think that our infrastructure can handle implementing a single payer system. So currently at the VA, there's almost 500,000 appointments with extended wait times, including wait times that are greater than 30 days and also waitlisted veterans who don't even have a wait time. They actually allocated $15 billion in extra funding, and it's still not meeting needs. They were actually so inundated with new patients that they weren't able to handle, and people are still waiting actually even longer now for care than they were before. From a systems perspective, we just really have to kind of take a look at what is going to happen. It is going to drive down the salaries for healthcare providers. The money has to come from somewhere in order to implement this system. And this system has been, single payer systems have been implemented in countries that are significantly smaller than the United States. So for instance, Canada has 35 million people in their population. Australia has 23 million. Spain has 46 million. The United Kingdom has 64 million. The United States has 318.9 million people in their population. It's just not possible. And we completely agree that healthcare is an absolute right. However, we believe that it needs to be made within the current framework that we have right now, because the cost is going to be exorbitant. So proposing a single payer system, Bernie Sanders currently is saying that it's going to cost $1.38 trillion per year over the next 10 years. So that's his proposal. So there's an economist named Dr. Thorpe who actually did a study, and he estimates that this is extremely, this is not actually a realistic number. He said it's going to be more like $2.5 trillion over the next 10 years. And so so where is that money going to come from? It's going to come from taxes. It's going to come out of your paycheck. So we're indirectly losing. So Bernie Sanders' plan, he's saying it's going to be basically a 6.2 payroll tax increase and a 2.2% income-based premium tax increase, which is totals 8.4% coming out of indirectly coming out of your paycheck. And then, but then when you actually look at it and analyze it, it's more like 20% loss of paycheck if you actually calculate the full cost of what this will, the full bill for what this will cost the United States. Although universal health care would be amazing and everybody would ideally have access to care, our economy would literally crumble under this kind of debt. So we have to be able to make changes within the current system in order to make this happen, in order to get our Americans better health care and also keep the quality of healthcare where it is, because the cost of this is going to definitely drive down quality of care. And if that happens, doctors are going to leave the countries and go other places to be paid for their services. And let's see. And that's it. Thank you.
So the opposition keeps bringing up Canada. I want to bring up the point that the United States is not Canada. We're significantly larger and different. So I'm just going to bring it back in within the borders. Currently, this year, annual healthcare spending in 2015 in the U.S. was
A
3.8.
little closer to the microphone, we can't quite hear you.
No, thank you. Oh, okay. Sorry. Do you want me to start over? Okay. So the opposition keeps bringing up Canada, but the United States is not Canada. This, in 2015, annual healthcare spending in the US was $3.8 trillion. In 2015, the cost of healthcare for a typical American family of four covered by an average employee-sponsored plan, the type of coverage that 57% of Americans currently have, is $24,671. This amount has more than doubled over the past decade. Healthcare costs in the US are rising out of control with the current prevalence of employer-based private health insurance. The employee cost for health insurance has risen 43% in the past 5 years. Employers are affected too, in recent years allocating over $14,000 to each employee covered under their plans. However, this leaves over $10,000 in healthcare costs for the family to shoulder. The median household income in 2015 was $53,000. Healthcare costs amount to 20% of the average American family's income. When surveyed, only 48% of insured Americans would be able to completely cover an emergency expense costing $400 without borrowing money or selling an asset. $400. Private employer-based insurance sets families up for financial risk when making healthcare decisions. But high premiums don't even guarantee high levels of coverage currently. 37% of the US went without recommended medical care, did not see a doctor when ill, or failed to fill a prescription in the last year.
A question, if I may. Going back, you were talking about healthcare costs and that 20%. I'd like to ask, what exactly does that 20% involve in terms of healthcare costs for the average American family?
It includes premiums from their insurance and out-of-pocket costs.
Directly towards their own healthcare, does that include taxation to fund public healthcare?
That includes them and their family alone. The current private-based insurance system is prohibiting Americans from accessing healthcare based on cost. A government-based system would allow for the government to fix costs for procedures so all Americans can afford care when they need it. Employer-based private healthcare lacks control of costs because it favors competition, turning the healthcare system into just another method of making money. A universal government-based system could allow for government caps on hospital spending and cost per procedure. Currently, millions of Americans are drowning in healthcare debt. As my person brought up, it's currently the #1 cause of personal bankruptcy. The average American has $1,700 in outstanding medical debt. And medical bills are counted on your credit report. Most people think that because they don't make it back to the major credit bureaus, but they do count. And in the future, it may be weighed less heavily, but currently it still counts against your credit score if you have medical bills.
How are we going to be saving money though if you're still going to be, we're going to have to tax extremely high in order to make up for this disparity? So what exactly, how is your plan going to save the American population more money? Because I just see it as another way. I just see it as another cost. It's just called a tax instead.
So we're just changing the location of the money, right? Like, so right now, you pay that money to a private insurance company. With a single payer plan, you pay that through taxes to the government. So you're just changing where the money is. And actually, single payer plans do decrease costs. Let me talk about administrative costs. So
not for the level of care that the Americans need. It's going to cost a lot more than what you're proposing.
So currently, the U.S. has a single payer system, Medicare. Medicare's administrative costs are 2%. The average private insurance company's administrative costs are 31%. And this doesn't even eliminate errors in administration. Insurers can't keep spending more on costs, but charges are slipping through the cracks. The two largest private insurers, Aetna and United, were cheated out of $60 million last year by a tiny surgery clinic chain in Northern California. So their high administrative costs don't even promote efficiency. They also cause problems when healthcare providers are trying to bill for services. So if mistakes are made, the cost goes to the individual. So I'm going to tell you a story that represents a population in the United States that's been denied under employer-based healthcare because of pre-existing conditions. So a pre-existing condition is a health issue that insurance companies have decided should limit access to care. Under the Affordable Care Act, insurance companies cannot deny coverage based on these conditions, a view into what the future of single-payer healthcare could be. Insurance companies have previously had denial rates from 24 to 40% due to pre-existing conditions. In Missouri alone, this represents 2.6 million residents. Under a single-payer system, these 2.6 million mothers, brothers, sisters, husbands, humans would no longer be denied coverage. There are countless examples of stories like this. Just ask your family, friend, or neighbors. But unfortunately, as the opposition has brought up, there are barriers to universal coverage. Universal coverage doesn't necessarily translate to health. The Oregon Health Study in 2008 found no difference in mortality, so ER visits, in those covered in insurance and those uninsured. However, preventative services such as primary care visits, immunizations, health screenings actually do contribute to health. And this has been proven by a myriad of studies. Notably, one by the Health Affairs indicated that preventative medicine is cost effective. This emphasis on preventative services is only achievable in a universal system. Private insurers don't have any motivation to manage chronic conditions. Under a single payer system, the government is motivated to take care of its citizens. Private employer-based health insurance is an absolute failure in the United States. Not all citizens receive care, and healthcare costs are insanely high. The thousands of private insurance plans make negotiation near impossible. The only solution is a single payer plan with the size and strength to demand quality healthcare at a reasonable cost. This is the only way that hospitals are forced to negotiate price fairly.
Size and strength. That means how that's going to cost a lot of money, and money that we do not have. This country will not be able to afford economically.
So it's size and strength solely in numbers because it's every citizen. It doesn't necessarily have to mean more money. You can put the same amount of money into one system and go from there. It doesn't mean that it automatically costs more.
But then the kinds of scans and treatments are still going to be expensive. That doesn't mean the cost of these new technology, these new drugs, all the things that all of this innovation that America has. Where's the funding going to go for that?
So for example, in Japan has caps for services, for fees. So an x-ray in Japan will cost the same amount no matter what hospital you go to. If the US implemented something like this, that is one example of how you could control costs. And dozens of studies of single-payer programs in the US have demonstrated this single-payer plan could provide universal coverage at a lower cost.
Where is that money coming from to make that scan cheaper? Where is it coming from? It's coming from somewhere. It's coming from somebody's salary.
Administrative costs. So that 29% that we don't have to spend on administrative secretaries, on paperwork, on billing, can be funneled back into the healthcare system itself to improving efficiency, improving wait times.
But you're going to need those secretaries and all of those people in order to organize this. We're going to be inundated with people needing healthcare, and who is going to organize that?
Excellent. Now you just created jobs. So now we have more jobs in the US.
But that doesn't necessarily mean that it's more efficient. You're saying that that 29% is going to come because we don't need all of these people, and we do. We actually are going to need more. And I agree, that's more jobs, but that's more money. And where is that money coming from? That's my question.
So the government can regulate efficiency.
Getting their money from taxes. So who is paying those taxes?
Everybody who's currently paying for private employer-based plans.
Taxes are going to have to increase in order to meet that demand.
Where? Why? What is the study that tells me that it has to increase?
It absolutely has to increase because of the cost, unless you want to inflate the dollar.
I don't understand why it has to increase, because you can take that same amount of money and funnel it into one system.
You're funneling it into one system, but the amount of money that's going in is not the same amount that needs to come out in order to give care, the quality of care that you were talking about. that we all want for everybody. It's
So
gonna
where's that money now? Where's that quality of care now? It's not. We don't have a high quality of care in the US. Millions of Americans don't have access,
You're
as you guys brought up. And so a single payer system can be
absolutely right. The quality of care is not universal. However, we can make those changes within the current system that we have right now. Instead of putting us into economic disaster with the kind of debt that you're talking about with universal health care.
okay. Bernie's healthcare plan that you brought up costs less than the current yearly spending in the US on healthcare costs.
Those are
I
his
don't understand
projections, and
where
they've
your
been proven
conception comes that it will be more costly.
Those are his projections, and they've been proven to be.
Sorry. I have to interrupt. We have to let her finish her points. There's bring a lot of points of attention, and we need to let her finish her argument. So, thank you.
Okay. So currently, 40% of Americans owe money to collectors for times that they've been sick. 63% have received a medical bill that was more than they expected to pay. So currently, nearly half of insurance claims examined in one study contained billing mistakes. So this is a huge drawback to the private insurance system. With complicated billing codes and procedures unique to each insurance, there's much room for error. If a single error is made, insurance companies can deny coverage, causing standard procedures to turn into astronomical bills for patients. Under a single payer plan, the government can regulate cost and demand quality healthcare providers at a reasonable cost. Thank you.
You guys hear me? Okay, so thank you. I'd like to thank the last presenter for bringing up her thoughts. I'm a logistics guy and a stats guy myself, so I'd like to address that specifically. She asked for specific information, and I can provide it. So she mentioned recently that Bernie Sanders' plan estimates that we would spend $1.3 trillion in order to fund this program, and that would actually save us money. So it's just funny to me that the guy who is running for president and needs votes is going to tell us the numbers that we want to hear. So an unbiased healthcare economist from Emory University gave a more realistic view on what it would actually cost. And as Lauren brought up earlier, it's going to be $2.5 trillion per year to fund that system. The taxes that Bernie Sanders estimates would be 8.4% in his plan, but in order to realistically fund it, this would be more like 20%. So not only would the Americans who pay for healthcare out of their own pocket need to have that 20%, now it would increase further to cover the new funds that we would need for this single payer system. So to further go along there, regarding the costs, we look at our own system in Medicare and Medicaid and say that the administrative costs are only 2%, which are significantly lower. But in a quote by our current President Obama, who is the biggest advocate for affordable care and his own Obamacare, stated that Medicare and Medicaid are the single biggest drivers of the federal deficit and the federal debt by a huge margin. In this country, Medicare and Medicaid public funding for public health care by the U.S. government is the single biggest driver of our national debt. Medicare alone, since 2006, has over $25 trillion in unfunded liability, meaning that they have funds they have promised to pay for health care for Americans more than they currently have current funds to pay for that. We're $25 trillion in unfunded liability. Furthermore, in order to try to correct that problem, in 2012, Medicare tried to compensate by reducing physician payments. So by trying to cap what they can charge for services and therefore what they can earn by 30%. So they reduced what they can charge patients by 30%, which would ideally help the American population. But this created this system still resulted in an unfunded liability of $1.8 trillion in debt. So even our own Affordable Care Act is what is killing our own economy. So to now put this on a national scale, where this system would pay for the United States for all citizens to have equal and affordable health care is just simply unrealistic. We can look at a system that was tried and implemented in our own country, since we do want to bring this back to the United States. In Vermont, from the years 2011 to 2014, they tried to implement a single payer system called Green Mountain Care. So what this did was essentially try to provide a single payer public healthcare system to the citizens of Vermont. It was projected to initially save the Vermont citizen and the state $590 million. However, they had to stop this program. By the end, this system was slated to cost Vermont $4.3 billion by the year 2017. This would have doubled their total budget for all programs for the state of Vermont, would have increased taxes up to 11.5% on payrolls and 9% on income, so a total of 20.5%. So not only did they not have the funds to pay for it, they were going to need to charge their own citizens more state taxes in order to fund the system. So if it can't even work on a minor state level, how is this supposed to work for the entire United States?
Hello, can you hear me?
Yep.
Okay. Given that Vermont is a predominantly white, predominantly sort of monotonous in their socioeconomic diversity, do you really think that that is a good representation of America? America whose population and demographics doesn't look anything like Vermont and has a very different funding system, has a very different, well, pretty much everything I can think about it is different besides it being just one section of America. Do you really think that that is comparable? Because Vermont, the demographics of Vermont, socioeconomically, racially, when it comes to funding, is very different than the demographics of America as a whole.
Thank you for bringing up the point. I'd like to see your specific stats on that, but to address the situation, you say I'm guessing you're assuming that they're higher socioeconomic status and a population that is generally healthier. Is that what you're implying?
Actually, not necessarily. Like, I don't know specifically. Here's what I know about Vermont. This is from 538, which is a statistical analysis, and it is over 90% white, but it is not a particularly wealthy country, and it's not a particularly educated state. My bad. And it has a very uniform demographic.
So, we're making assumptions about a state and we're trying to generalize, but the fact of the matter is, they're a lower socioeconomic status. So in this system that is designed to help people of lower socioeconomic status, and yet in this state it did not work.
Oh, so I don't mean to say that they are like federally impoverished. If you want to talk about states that are federally impoverished, Mississippi, Kentucky, Indiana, there are a lot of particularly southern states that are 30% of the state is impoverished, or at least near the poverty line, or living below the quality of life that is set for America. Vermont is not one of those.
Yes, but they're still American citizens, and so if they're not as impoverished, right, they would essentially be able to afford paying these higher taxes because they are not as impoverished as a state such as Mississippi. So even in the state where Vermont, where they are not as impoverished, they cannot afford this healthcare system due to the extremely high taxation rates. So does that answer your question?
Yes.
So one more point I would like to continue on, looking at now, I guess, the general population of the United States. We are a country that is getting older. The baby boomer population is just starting to grow. As of 2010, 48 million persons were enrolled in the Medicare system. By the year 2030, or by 2020, that's going to grow to 64 million. And by 2030, that's going to be up to 81 million. So with the current enrollment of approximately 54 million, adding a few years since that stat from 2010, this program is not able to support these citizens, and we're driving a national debt crisis. How is that going to be changed with a fully funded single payer system where by the year 2030, the required citizens needing this public funding system are going to grow, and the funds available to support that system aren't going to be able to match it? This is going to result in a decreased quality of care because they're going to have to allocate funds and restrict funds for only the sickest of patients. They're going to have to limit costs of that physicians are allowed to charge in limiting wages. They're going to have to limit the availability of new technology. They're going to have to limit the availability of new innovation. For new innovation in this country, 75% of all clinical trials in medicine is funded by private insurance or private companies, 25% by federal funding. When you limit the ability to earn and you limit costs and you limit the ability to earn, what would the incentive be for those private companies to fund research? There won't be any, so they're not going to do it. And where's the innovation and the funds going to come to innovate new medications to further increase the quality of care? It's not going to be there with a single payer system. Thank you.
Now that we're entering into the whips, I would just like to remind that even though it's been a great debate and point of contention has been the highlight of this, there cannot be any more high point of contention. So um, let's keep on with the debate. Thank you.
And thank you. So just to summarize, a single payer system is a system in which a single public or a quasi-public agency organizes healthcare financing. However, the delivery of care may remain in the private sector. While the U.S. implements the Affordable Care Act extended single payer programs such as Medicaid and Medicare, which itself are single payer systems, the U.S. is not a single payer system, but it is considered a single payer system. So I would like to bring up the point that you said earlier, and I'm really glad you brought it up, but it would be advantageous actually to have universal healthcare, which would be what a single payer system would be striving for, because healthcare would be paying for everyone. While right now we have a problem in which 2.5 trillion, and you brought this up earlier, you said that Bernie Sanders' problem would be would eventually have to pay 2.5 trillion by the taxpayers. Currently, I'd like to remind you of this number that 3.8 trillion is the annual amount being paid this year for healthcare. So that would actually be lowering the costs as to what we're doing right now. So the affordable healthcare would be a single payer system that would help, because you bring up the next 10 years. But let's not think about the next 10 years as we have brought up before. Let's think about the next decade. Let's think about our future in which everyone is paying for everyone instead of simply this 54 million on Medicare, in which we have older people that are benefiting while younger people have to pay into it. So yes, it is important to remember that a single payer system, while not technically universal, would be striving for the ideals that a universal healthcare system would be for. And now, it's also important to remember some of the heart-wrenching facts about some of the families that just can't pay for it, can't pay for simple medical problems that occur every day. We're talking about trying to help them in the long run. We're not talking about the next 10 years. We're thinking about the future. We're talking about what's happening right now. I'd like to bring back up some of the numbers that we were talking about. The type of money we're talking about is $24,000 $1,675. So that's the amount a normal family is paying right now on annual healthcare. It's rising out of control. I mean, the more people that pay for this healthcare are just going towards older people who are benefiting only from this system. Healthcare prices are, sorry, only a small amount of the actual healthcare is only a small amount of the actual healthcare. 20% of that goes into goes into the healthcare. So that's, sorry, 20% of that goes to the healthcare, only a small amount. That includes premiums, their families, the family alone, and the healthcare. So in summary, it includes the benefits of a single payer system include allowing millions to, it includes disallowing millions to suffer because they lack insurance, economic gains possible when they are insured, and everybody in the world that increasingly believes in equality and justice among all citizens. And that's what we're talking about when we talk about universal health care. It's important to remember also that while we look at Canada and other people's systems, it is also important to remember that we are a very developed country, and we're one of the few that does not use universal healthcare system or a single payer system. And you bring up Canada, but Canada isn't a system that works. And when we have people on those wait lists, I mean, they'd rather go to America and get healthcare here because they just don't know how that system works. We're not talking about imperfect systems. We're trying to come up with the best one. And yes, there are systems that don't work. There are systems that clearly shows it's not currently working, and we're talking about striving for that. And it's important, I think it's important to remember what the opposition is bringing up, because these are the things that we would remember in trying to create something that would be better for the American people.
All right, thank you. So I just want to reiterate some of the points both sides have had, and reiterate some of our points. Specifically, I think there's been some confusion from both sides about deciding exactly what single payer means and exactly what that covers. Through everything we've researched, a true single payer, it just, as we've stated, it would not work for this country with our economy. There's parts, we recognize, just like you all do, that there's a lot of our current system that's not perfect. I think it's important to highlight the parts that are really great, which is why people do travel here for some services. I have from the National Center on Policy Analysis, the 10 most frequently described prescription drugs and most common surgeries in the world, including that take place in countries that have a single payer system, were originated in the US because of our innovation. So there has to be a way to have a system like what we have now that's better, and we've been moving in that direction with parts of the Affordable Care Act. There's been some good parts about it that needed to happen, but that doesn't mean it has to be a single payer system to maintain some of those parts, like the pre-existing condition piece that came up. Yes, that's good that health insurance companies now have to acknowledge that and accept people. Loan forgiveness programs now with healthcare professionals entering into the workforce. I'm part of that. There's also been an emphasis with Affordable Care Act on primary care providers and creating more of a medical home for people. This brings up the prevention piece that we all seem to agree on. This is a huge piece. The biggest health problems in our country with chronic disease all stem from health behaviors. And health behavior change is complicated. Having a system where we're reaching more people and it's straining the system because it's managed by one single entity doesn't sound like it's going to guarantee that a physician or an OT or a PT is going to get the time they need to truly sit down with someone and talk about changes that need to happen, talk about what's going on at home, talk about stress. Stress is a huge contributing factor to diseases. And that stuff is complicated and it takes time to make those changes with people. And so just reiterating, a single payer system is not going to make that quality of care piece change necessarily. So keeping in line with what the good parts of Affordable Care Act, like I mentioned, incentivizing prevention through possibly higher salaries for primary care providers, implementing programs like that can be more effective, having more community-based changes that affect more people can bring better health outcomes without necessarily having the single payer system. So as I opened with stating that this is an ethical dilemma because it's healthcare and healthcare is a right for all of us Americans and our loved ones. And a single payer system, it sounds great on paper, ideal, but it just simply, the reality of it does not work, and it would bring more of a burden to our country and not the change in health that we really need for our country. Thank you.
Thank you, everyone. That was a lively debate. Yay, good job, everyone. That was wonderful. So we're going to give our two judges here on site some time to deliberate, talk about their scores, and award a winning side. In the meantime, I'd like to invite some Q&A and dialogue. Debaters, if you have, I'd like to invite you guys up on the stage if you want to grab those hand mics.
I do have one question for UNE's team. We just want to make sure we have your names right. The person that spoke first and last, what is your full name?
Can you hear me?
Yes.
It's Liz Crawford.
Liz Crawford. Thank you. And then, okay, the person that spoke second? Yes?
Lauren Zito.
How do you spell your last name?
Z as in zebra, I-T-O.
Z-I-T-O?
Z-I-T-O.
Z-I-T-O, yep.
Oh, thank you. Thank you. Okay. And then the gentleman on the panel?
Matt Devine, D-E-V-I-N-E.
Great. Thank you. We just want to make sure we have your names right on the ballot. Thank you.
Great. Okay, so we'd like to invite questions, whether debaters, if you have questions for the other team, UNE, if you have questions for our debaters, we'll also open it up to the audience. I just ask if you're up top that you speak up a little bit, and I'll repeat the question into the mic.
I'd just like to start off by saying thank you guys for having us for this debate, and it was a great experience. Definitely a new experience. I think I was, at first a little confused. It seemed like you guys had full-on speeches that you had prepared, covering multiple items, where I think we thought it might have been a single point of argument to contend. So that was a good challenge, though. But it was a great experience. So thank you.
Okay. Why don't you look right? Okay. So first of all, I'd like to apologize for being kind of belligerent. You guys brought up great points. We were like in the process of like thinking like, what you guys would say. We're just like, are they gonna say this and this and this and this? And then you guys like,
Wait, can you turn it up? We can't hear you.
sorry, can you hear me?
Kind of.
Okay, so
That-
when we were thinking about what you guys were going to say, we were thinking about, you know, what the common arguments were. But then you guys came up with like really great like research and evidence and like statistics. And we were like, this is not the normal conversation. This is not what like the normal argument is. And it was really great. And we had a lot of like points of contentions. And it was really great to have sort of give and take.
Yeah, I mean, I think you guys did an awesome job, and I think that we thought we had the harder argument at first because we thought, oh my gosh, like universal healthcare, of course, that's what everybody wants, and so we kind of struggled in the beginning to really find an argument because obviously that's what everybody would love would be universal healthcare or a single payer. So I think that you guys did a really great job, and we tried our best because we definitely had to kind of dig deep. But once we started uncovering things, I think we found some good arguments. But I think we had a really good back and forth between the two, and it was awesome. We definitely learned a lot.
Thank you. I think the judges are ready.
I haven't even introduced the judges yet. So Tony, perhaps if you
We
guys
have
could.
an audience member
Sorry.
question.
Oh, we do have another question. Yeah, okay, go for it.
Yeah, so I was just confused on, you mentioned that it would cut the administration portion of our healthcare system right now. And I also heard you say that it would add jobs somewhere, but to me, the cutting of administrative costs kind of, or administrative portion of that kind of takes away jobs, in my opinion. And I was just confused as to how that would work for you. And then the other thing that I know in talking with some of my colleagues in our program, Taiwan and Canada are the only true universal healthcare countries, and I just wanted to see if you guys could touch up on that as well.
Yeah, so I can start with what you brought up, kind of administrative costs. So currently, administrative costs in two private health insurance companies typically go to workers who go through claims on claims on claims, right? And so under a government system, one possibility is to standardize that. So like under Medicare, I know some health professionals don't necessarily like it because you have to fill out extra paperwork, but there are like specific procedure codes, and you have to fill out like Medicare specific paperwork, so it just streamlines the whole process. So that kind of was what I was getting at. Does that make sense?
Yeah. Yep.
No, okay. Sorry.
We appreciate the questions. I think it's important that we keep the thing moving. My name is Tony Breitbach. I am one of the athletic training faculty. I'm the director of the AT program, and I am co-instructor for IP 110 with.
My name is Katie Elliott. I'm an assistant professor in the nutrition and dietetics department.
And we are just thrilled that we are able to do this with our colleagues at the University of New England. We think very highly of your program, and it's exciting to be able to do this with another IPE program. So one of the things that was really important as we go forward, we really need, what's nice about the British parliamentary style of debate is that there's a set structure. And sometimes it's hard to stay within that structure, but I think that's one of the reasons why there's a structure built into the system, so it allows people to interact. But I think Gerardo did a good job of getting things where they needed to go. So we appreciate his work. We also appreciate the work that Annie Rosencrantz has done in setting this up. It's amazing. So what we've done is we've actually, the way we do it is we have it broken into 4 teams, and we recognize a first place and a second place in the teams. And then we also recognized two top scoring individuals. Okay. So what I will do is I will identify the top two individuals. The top individuals was Amelia Meggs. Congratulations. And the second individual is Matt Devine. Congratulations. Nice job.
Great, and I'll do the teams. The first team was the SED team. The first team to present was first place, so the first government position. And then the second team was the second opposition from the University of New England. So congrats on second. The third place was the second government from SLU, the SED team. And number 4 was the first opposition from the University of New England. So thank you all for everything that you added to this debate.
Okay, just to follow up, we had a photographer here from Boise College of Health Sciences, and he will be doing a photo gallery of the event, so you'll be able to use those as you'd like. But we really appreciate everyone's involvement, from our panel here, from our colleagues at University of New England, and and Jeff Nevers, he's not here right now, or he is?
I am.
He's
Yeah.
over in the corner.
Yeah. Hey.
Hi.
Oh, cool. Do you want to say a few things?
Thank you very much for putting us through the paces tonight. I thought this was a really good experience. This is the first time I believe we've ever done anything along this line, so it was a learning experience on many fronts. But it was a worthwhile evening, and hopefully we got quite a bit out of it. I found it to be very interesting. So
yeah, we're always interested in doing things again. So if you're interested in challenging us to a new one, we're happy to do that.
We've got a nice gym not too far from here. We'll get them in, get the boxing gloves on, and away we go. And we'll be in touch in the next couple of days as well.
Thank you very much. We appreciate it. Nice job, everyone. Nice job.
Thank you guys. Have a good evening. Thanks again.